Hello. Good evening, everyone. I'm Fanindra from Vision 2020, the Right to Sight India. I welcome you to this webinar on low vision and rehabilitation in partnership with CL Gupta Eye Institute, Moradabad. We will run this session for an hour, and Vision 2020 has been organizing various webinars under its Knowledge Hub initiative. So this webinar is yet another very important to bring in some quality and good practices that our member hospitals can learn and implement at their settings. And this webinar is essentially a recall of a day-long conference held at CL Gupta Institute on low vision and rehabilitation. And we would like to share the key observations and learnings from this conference held in the month of March at CL Gupta Institute, and also the exchange the ideas with Vision 2020 India partners on further strengthening the low vision and rehabilitation services across our country. And we'll be happy if we're able to draw at least one key recommendation for advocacy with the government and with other stakeholders by end of this session. So I'm happy to introduce the speakers, the panelists of the day today. So we have Dr. Ashi Kurana. Dr. Ashi is the Vice Chair of CL Gupta Institute. CL Gupta Institute is the NABH accredited multi-specialty not-for-profit eye hospital with an extensive outreach program. The institute has a rich optometry academic atmosphere and has been providing low vision services in the area for the last 10 years. So Dr. Ashi is a cornea specialist by training. She got trained at LV Prasad Eye Institute, Hyderabad, and she initiated a modern eye banking in Moradabad division. Thanks, Dr. Ashi, for planning and designing this session. Thank you very much. So then I'm following to introduce other speakers as well, the panelists for the day. We have a panel member, Ms. Binni Kumari. Currently, Binni is working with CL Gupta Institute as a communications cum rehabilitation officer. She is a professional in the area of visual disability for more than a decade. And she is a graduate in political science from Delhi University, and she has various certifications in counseling, mental health, employee empowerment, human resources, business communication, etc. In the past, she was associated with the SCORE Foundation and volunteered with various organizations for the cause of blindness and low vision. Thank you, Binni, for your time today. Then I have our next panelist, Dr. Sumit Grover. Dr. Sumit is an ophthalmologist and he is associated with the Manthan Eye Healthcare Foundation, which is an NGO working actively in the low vision domain. Dr. Sumit also has an MSc in Public Health from London School of Hygiene Tropical Medicine and was awarded Eye Health Hero in the year 2020 by IAPB. He also authored a book on low vision, not no vision, and that's kind of the book title. And Dr. Sumit conducted clinical research and coordinated trachoma surveillance surveys and other surveys also. Thank you, Dr. Sumit, for your time today. And then we have Professor Maunika Chaudhary. Professor Maunika is a consultant optometrist and educator and has 33 years of experience in clinical, industry, and academics. Professor Maunika was associated in the past with the AIMS, All India Institute of Medical Sciences, IGNO, Amity University at various capacities. And she's also a key opinion leader for eye care industry. So Professor Maunika authored books on low vision, contact lens, and refraction, and has published several papers. Professor Maunika has been awarded the Shrestha Shri Award by the Delhi Citizen Forum, Australian Leadership Fellowship Award in 2011, and Global Educator for the Year Award in 2015. Thank you, Professor Maunika, for your time and availability for us today. Then I have another panelist, Mr. Mahendra Singh. Mr. Mahendra is currently associated with the CL Gupta Institute, Moradabad, and he has done a master's degree in optometry from Chitkara School of Health Sciences and 2 years comprehensive optometry fellowship from LV Prasad Eye Institute, Hyderabad. So he is passionate about bringing improvements in the area of low vision and rehabilitation. Thank you, Mahendra, for your time today. And we have the last one, we have not, but not the least, we have Nikita Sethi. So Nikita Sethi is currently working as assistant professor in SGT University, Gurgaon. She has a master's degree in optometry from MT University and one of the contributing authors in the 8th edition of Comprehensive Ophthalmology, a kind of book by Professor A.K. Khurana. So she has keen interest in the fields of cornea and contact lens, low vision and community eye care. So thank you, Nikita, for your time with all of us today. So there is a Q&A box at the bottom panel below. So you can type your questions during or at any point of time that you feel. But we will take up all the questions at the end of our talks by the panelists. And so I'm thanking all the attendees for joining us today, and also all the panelists and the speakers today. So we also thank Orbis for providing us the CyberSite platform on which our current webinar is being hosted. And a special thanks to Mr. Gangadhar from Sydney, all over from Australia, who is now with us for all the support from CyberSite. So thank you once again for our participation. So now I'll request Dr. Ashi to have a talk, to present her talk, then followed by our panelists, which I will invite after Dr. Ashi's talk. Thank you. Over to Dr. Ashi.
Thank you, Dr. Phanindra. It's my pleasure to present. Can you view my screen?
Yes, we could see, yes.
Yes, so I represent this beautiful CL Gupta Eye Institute. And to introduce the topic today's webinar is about low vision and rehabilitation. We all know that low vision hampers the quality of life. It restricts the growth and job prospects of a person. But we also know from publications that 85% of the visually impaired have a potential for residual useful vision, only if there is a timely detection and a referral to a proper rehabilitation service. Now, mostly because there's a lack of these facilities and there's a reluctance of eye care fraternities to refer these patients, we have been conducting rehabilitation workshops at CL Gupta Institute, and the last workshop that we attended was the 5th such workshop on 27th of March this year, and 6 experts who have been recently introduced by Dr. Phanindra were invited as faculty who conducted informative panel discussions, lectures, and hands-on sessions. And there was an audience of 156, mostly comprising of practicing optometrist students and ophthalmologists. The idea of this webinar today came from the Vision 2020 team, who suggested that we share the learnings of this workshop, the same faculty, in a concise form, and to share the key observation and learnings from the webinar, not to share the same presentations again, but whatever we have learned and exchange the ideas with other Vision 2020 partners, how to strengthen the present LVA and rehabilitation services in the country. What were the key topics that we covered in the CME? Were the types of eye disorders causing low vision, how to do low examination and assessment, and demonstration of devices, hands-on. There was also sessions on rehabilitation. So people generally need to understand what is the difference between low vision and rehabilitation services. And we had demonstration of educational and digital training and vocational training activities that were going on at CL Gupta Institute, and also we had sessions on challenges which unsighted person faces and how he overcomes them. These are some of the glimpses of the webinar, photographs of the chief guest inaugurating the sessions and the didactic lectures. Then there was workshops. And many of these, practicing optometrists had held the LVA for the first time, device first time in their hands. This is the entire youthful audience who had attended the webinar. This was the agenda. The pre-lunch session comprised of first an introduction, followed by history taking, which is specially designed for low vision patients, and various how to do examination and other investigation, devices types. Then disorders and epidemiology was taken by Dr. Sunil, then management of a patient, then magnification calculation, device dispensing. Binny very appropriately had talked about coping up with blindness. There was another lecture by Dr. Sumit on co-management and community involvement. And Professor Monica had talked about specific diseases and low vision devices that are appropriate for them. After lunch, there was this workshop where every participant got a hands-on demo for various low vision devices. And then there were these 5 halls where the participants would be rotating and learning various skills like history taking, refraction, vision assessment, device demonstration, and how to set up a low vision rehabilitation clinic. And then there was a live performance for vision rehab and severe vision impairment situations. This was followed by a quiz after the workshop. So these are some of the topics, the presentations that were there in the conference. There were some issues that had been drawn from the CME, and there were during the Q&A and the sessions, and this I'm sharing with you after a discussion with the low vision department at our institute. The first and foremost important time key issue that came out was the lack of time with the medical professionals for counseling and sensitizing those clients who are either on the verge of losing eyesight or have lost their eyesight. So in a busy OPD, it is almost impossible for a medical professional to do the counseling, hence the need for a low vision department separately where the patient can be counseled and the responsibility is passed over. The second issue that and the challenge that came up was that low vision and rehab is not a career priority with most of the youth because it is not a commercialized branch as compared to more, it does not have that kind of professional weightage as compared to the more glamorous branches like contact lenses, which are viewed as more commercially viable. The other challenge was there was a lack of awareness in the medical fraternity about the possibilities of blindness rehabilitation, which leads to no guidance from doctors. So basically doctors themselves who are at the end of the, who are the last point of contact for a patient when he is told that he is not going to get vision in his life. So at that point of time, there is no guidance from the doctors about how to deal with the disability. And this is mostly because low vision and rehabilitation services are not a part of the teaching curriculum in most of the medical institutions. So that is also one major challenge. Another challenge that was faced by most low vision services is that the proportion of investment and the return of investment actually is not that much. So the running of the rehabilitation services is mostly dependent on compassion of the organization or support services. So we need to really think of ways to make the rehabilitation and the low vision care more viable for organizations to run and profitable if possible. The other challenge is that there is a lack of awareness about the rights and benefits of the visually handicapped. So this lack of awareness is a major issue. And I highly recommend this book by our eminent speaker for today, Dr. Sumit Grover, and with contributions from Monica Chaudhary. And I would recommend all of us go through it. The other key issue or challenge is the lack of acceptance in the family members to invest in the treatment and rehabilitation. So how do we get this into our circle of control is probably by creating more faith in rehabilitation, share the success stories of rehabilitation more aggressively in the community. There is also the other challenge is the lack of an ecosystem, which probably not much can be done. Which an ecosystem which can enable the stakeholders or visually handicapped to explore the possibilities for themselves, meaning because of illiteracy, poverty, so many issues are there. So it is not very easy for people who are already suffering from blindness and or low vision to look at how and what can be done for themselves. That's also one very big challenge. Creating public awareness is also one thing that can be done here. Another big issue is finding funding agencies, because the impact that is calculated by uh, a funding agency is by what difference it is making in numbers. So that is also one challenge in low vision rehab, because we do not have that kind of numbers like what they get for support for cataract surgeries. I would just also like to share with you here the feedback of all the participants, 156 participants. They were all, like I mentioned, audience was practicing optometrists, students and ophthalmologists. They were from UP, Haryana, Delhi and Uttarakhand. So I thought I'll share with all of you. Most of them were youngsters, and 62% did not have vision rehabilitation, and 89% felt there was a need for vision rehabilitation in their field of work. And on asking them whether they had VI patients in their practice, 58% said they did have VI patients, and 80% of them did not know how to help these patients. And most of these patients, which these participants, our audiences had seen, were suffering from low vision, and 60% of these patients had found it very difficult to manage their daily activities. And on asking them, our audiences, what is their experience of handling VI patients, 68% had said they had no experience, which is a very big number. And in patients with blindness, also 32% said they did not know what to do. Even asking these qualified people also, if a person, simple question like if a person becomes blind due to glaucoma at the age of 40, 85% did not know what they would be doing. And although most of them said that rehabilitation services were not uniform, we had asked them what are the measures that they think. So there were various ideas that came across, and first was of course only refer. Second is to improve the low vision devices and providing low vision devices, and the other idea was to open new rehab centers across various locations, and to create awareness. So more awareness programs for creating awareness about low vision was another point that was suggested. Even a simple feedback about why literacy rate in the blind is low. We had come up, people had given their insight by giving us some ideas about, because there were lack of schools, there was a lack of awareness, there was non-availability of devices, there was lack of education and cultural myths. In the end, I would like to come to the recommendations based on the issues that were raised. One is that there should be at least a low vision or rehab cell in high hospitals for these services. If it is not possible, then at least one should have a contact information center in all eye hospitals to refer the clients to the appropriate places. And more CMEs are required for medical fraternity. That is not only students, but also for practicing ophthalmologist and optometrist. Low vision rehab should also be commercialized so that it becomes a self-sustaining service. And other issue which has been raised is about developing innovations of manufacturing of low budget and effective low vision devices. Although a lot of work is already going on, Omtao and Arvind are doing a lot of good work in this direction. Another recommendation is that it should be a part of the medical curriculum, so that the last point of contact, like I mentioned, the doctor is familiar with the patient's need of low vision and severe sight loss, and the loop of care is complete at that point. So thank you, Dr. Fanendra, for this. And I think we can go on with the discussion from here.
Yes, thank you, Dr. Rashid. I think Very really a wonderful presentation covering the key issues and recommendations in a very concise manner. So issues like you mentioned, not a career priority, and also return of investment and lack of ecosystem. And also, surprisingly, 80% of attendees do not know how to help the low vision patients. I think these are really important issues that all of us as a stakeholder need to really deliberate further upon. And also recommendation of at least if you don't have the service cell for the low vision rehabilitation, at least having the information center. Okay, there also at least to the minimum that the hospital can do, definitely, and also making it this part of the medical curriculum. Those kind of recommendations are also really very good. And thanks, Dr. Rashi. Thank you so much. So we'll take up the questions at the end of all the presentations. And so I'm now inviting Binny Kumari. So Binny, now the floor is for you.
Binny needs to unmute. Yeah.
Am I audible?
Yeah, you're audible now.
Okay. So I respected all the dignitaries, all the respected speakers, and dear participants. I hope all of us are in the process of learning, and we learn each day. We'll be learning a lot from today's session also. So I have, I'll just be focusing on few things. So my recommendations are based on the presentation which Ashi ma'am has given in light of rehabilitation. So I'll be focusing mainly on medical intervention that would include detection and protection, prevention of vision loss, awareness and sensitization, education, employment, data representation. That's key, based on which all the policies and everything is made. I move to my next slide. First of all, we need to understand what exactly rehabilitation is. Rehabilitation generally is understood as if a person is blind, has lost their eyesight completely or partially, or a person is a low vision, then people simply think inko NGO mein dal do, put them in NGO, put them in some blind school, but actually it is not so. If we talk about rehabilitation according to WHO, which is a global health organization, it is basically it is basically set of interventions which can enable a person and disable the environment and disable the conditions which make the person feel disabled in medical context, in health context. So given this definition, keeping this definition or applying this definition, I move to my next slide. So basically, what I want to draw your attention to is that when we are enabling a person to improve the functionality of a person in all situations, in all contexts, then we need to rethink whether we want to just call low vision consultation rehab service or just dispensing the devices. So even in low vision consultation, dispensing the devices is not the only solution. It is more than that. We have to understand the person. We have to, it is beyond measuring visual acuity. So you have to get to the level of the person, so that person opens up with you and shares what exactly he or she is facing and what type of solutions actually he or she needs, and what will work for him or her. So I move to my next slide without taking much of your time. My recommendations, as I briefed you in my second slides, are according medical intervention, where I want to draw your attention to if something can be done, and this should be government policy, that prenatal checkups, if disabilities are detected, then the counseling should start from there. The rehabilitation of parents, like in the context of counseling, should go on, and they should be made prepared, like mentally, that like any other child of yours, he or she, a person with child with disability, is an important human resource. So that the rehabilitation actually starts from detection and prevention. I think these are the first steps. And who can be the game changers? I think community health workers, other than doctors, of course, the nurses, of course, but community health workers, if they are aware, if the ideas go into their head, I think there will be a lot of change we can bring. I move to my next point. It is very important, in my experience of 10, 11 years, what I have realized is that people waste a lot of time in just looking for the treatment, medical treatment, where when it is not available, in the hope one day we will get better, I'll get my eyesight back, then I'll fulfill my dream. So it's, if information on eye disorders, especially untreatable eye disorders, is disseminated in under government health programs, I think that will bring a lot of change. I know it will take time, and accepting is something which takes lots of time with many people. Like people spend 10, 20 years in accepting their blindness, then they come out, then by then the age is over. I move to my next point, which is education. In my experience, education, people in the hope of medical treatment or regaining eyesight, people lose, especially children or their parents, don't accept that there's a life ahead with blindness and low vision. So they invest a lot of time in treatment, and education age is over. I would like to draw your attention to the fact that between 5 to 15 years of age, there are 20 million children. So we need to, I think, if we can cater to that group also, it will be good. Employment, I would recommend that income generating livelihood programs should be introduced more and more. If you just provide vocational training, that will not help. If person is given vocational training but not employed, not given this some sort of business, then there's I think vocational trainings don't make much sense. Then I come to my next point, which is data accuracy in data presentation. I see a lot of mismatch in data presentation from the perspective that how disability certification is done. And I would recommend here that if a person is able to use low vision device, that disability certification should be done once low vision consultation is done, and with the help of device based on the low vision device, because that improves his or her functionality, but that is not done. So and appropriate, sometimes what happens, people, those who are filling the data, they themselves don't know how to fill, what to fill, where to fill. So there also things go wrong. Data representation create data is very important. It leads to various policies, and once if the data is not correct, policies are wrongly created or implemented. and the needed stakeholders are not actually benefited. Thank you so much for your time and patient listening. I hope we all will be benefited. Thank you so much. Happy learning.
Thank you. Thank you so much, Binny. I think, very extensive presentation. Also, you brought some important points, which we'll discuss now. We also request our audience to comment upon, your ideas and kind of thoughts, particularly on the detection prevention during prenatal and postnatal period. Also, good idea about the income generating opportunities, not just only vocational training, but also really opportunities for them to generate their own income on their own basis and experience. So I think so we'll take a note of it. Thank you so much, Sabini. So we move on to now Dr. Sumit. Dr. Sumit, if you could have a presentation.
Yeah, thank you so much, Dr. Phanindra, for giving me this opportunity, Dr. Ashi Khurana. And I don't have a presentation, and I would like to congratulate Dr. Ashi and thank her for, recapitulating what we, we have presented in that workshop on low vision at CL Gupta. And I would like to just, reflect upon and contemplate what Dr. Ashi and Bindi Kumari in her thought-provoking presentation has highlighted today. Going to my presentation, that what I presented, all the key recommendation points highlighted by Dr. Khurana, I could see that majority, the crux was the lack of awareness, and on both the parties, on both the ends, whether to the low vision professionals and whether they are the end users or the patients of low vision and visual impairment. And other thing, I would definitely come on to Binni Kumari's concern and very thought-provoking points she highlighted. I would definitely like to, comment upon that. But what was my experience when I, presented the talk on the low vision rehabilitation? Basically, I delivered a talk on definition of an epidemiology of the low vision in the first part of my presentation. And I was very much surprised that, the basic definition of low vision, the functional definition of low vision, the NPCB classification, these were something, things which were not known by the optometry students. And this is because the due importance of the community optometry principles or the low vision subject has not been imparted through the curriculum. The curriculum is not is only designed for the catering to the medical model, which was outdated. In 1980, the ICIDH was the definition used, and the of the disability was used, and it focused on the only the medical model, that there is an impairment, and because of that impairment a person is not able to do what a normal person of that age can do. So it is only the medical model was propagated. But in 2011 we came up with the ICF, International Classification of Functioning, which omitted these terms and moved from medical model to the social model. Then they suggested that it's not only the impairment of that particular individual, but the barriers created by the environment around that person, they have the important impact on that individual. So we moved from medical model to the social model, and we came up with the terms like participation restriction, etc., not just the handicap. So it was very much a valid point that things should be the in new education policy and in ophthalmology as well as the optometry curriculum, these things are very much needed. And I must say that hands-on training on low vision, they are also very important, because as we if we contemplate on the results of the feedback of the students, 80%, 90%, majority of them do not know what to do with the patient comes to them and in their practice, and they are if there would have been a question that what modality do you use for the low vision rehabilitation, I bet that more than 90 or majority of the professional would have named magnifiers, telescopes. That is it, because this is the long question which comes under the low vision category, and people know about this only. But the low vision rehabilitation has now moved to, with no financial interest, I have moved to smart glasses, head mounted devices like Onyx for central vision loss. We embark upon ACE sight, E sight, and many others. And the major problem what we face is that there's two things. The important barriers are, one is lack of training and awareness. I think that is the most important thing which should be carried forward, and there should be a common consensus and the recommendations from the fraternity that how to improve, or how to, I would like to hear Professor Monica's views on that how she has come up with a new model of digital education, and how we can impart training to the non-ophthalmologist human resource, especially because the ophthalmologists are very much busy in their OPDs doing surgeries, and it's time for the task shifting of this low vision rehabilitation services to the optometrist fraternity. And the second thing is the end user barriers. Still there are many things like shyness to use this, and a intrinsic, inherent attitude that this is out of my scope, these are not affordable by me. But I would like to highlight that there was a time when telescopes, even a normal telescopes and magnifiers, were very costly. And the thing is, when there is lack of awareness, there is, a lack of felt need, then the demand is low. When the demand is low, then the production cost, or the production cost per unit volume, and the import charges, etc., because there is no indigenous production manufacturing of these low vision devices because of the lack of felt need and decreased demand. So if we break this vicious cycle by just creating awareness among the community that the low vision and blindness is not are available, and not just, highlighted by Binny Kumari, it's not just about the low dispensing of the low vision devices, it's just a medical rehabilitation. But a comprehensive rehabilitation also, includes the social and vocational rehabilitation, that how we can do them, impart them orientation and mobility training. When we are not aware that how to, give them orientation mobility training, how we don't know what are the schemes which have been sponsored by the government of India for the visually impaired. We do not know what is the benchmark disability of 40%. Then how we can, think that the patient would have, demand needs and rights, and they can, ask for their rights. So it's the onus is on the healthcare providers, and mainly on the shoulders of, primary eye healthcare providers, because of they are the first point of contact. And CL Gupta has, I think, a well known optometry program, and I believe that these education and things should be imparted to the optometry students, so that they have the knowledge they can impart. Then this vicious cycle of, lack of demand and lack of production could be break. And there are newer horizons, as Vinny and Dr. Khurana mentioned, that yes, they have started the indigenous production, like of a glass thing by Arvind, but which can be used for patient of vision less than 618 to PL positive. Many assistive technology devices, from talking clocks to, talking thermometers, which can make the life of these people easier. So I think these are some point I want to highlight. And thank you so much for the patience listening. And I would like to, hear the next few speakers, and I would like to comment more over iteratively in the coming discussion.
Thank you so much, Dr. Sumit. Um, I think you touched a very important points in very last time. You also mentioned like lack of training and awareness, end users barriers, and also schemes of the government for rehabilitation, etc. So I think we will deliberate upon those issues. Thank you for really bringing those kind of issues to our attention. Thank you, Dr. Sumit. So now I request Professor Monica Chaudhary.
Thank you so much. In fact, I congratulate CL Gupta for a wonderful CME which was conducted, which was need of the hour. And I also congratulate Vision 2020 for taking a follow-up on this, because obviously it was not the end what came up in this. I have 3-4 points I'll just be talking, and our previous speakers have already highlighted most of it. So we've been talking about knowledge and training of optometrists at the university level, and I've been teaching for last 3 decades in universities, various forums, and certainly one of the low vision educators, it's not wrong what we are teaching as an optometry curriculum means. We teach the complete curriculum in how to calculate things and how to provide the devices and things like this. But we do not at university level make them industry ready. We may teach telescope, but we do not teach them how the telescopes, where to procure them, what is the brand which is there, how to get into this. And students do not get access to the clinical services in their universities. So very recently we designed a Learn Beyond Vision course in low vision, and success story was 40 students who participated in this, including 9 ophthalmologists in 7 countries. 16 of them straight away went into low vision practice. So my whole thought was, for years that I have been teaching, I can count on fingers the number of students who actually drove themselves into a low vision practitioners. So there has to be a different model. A curriculum, of course, is complete, and maybe a revision based on the upgradation that has happened in the sciences. But what is important is understanding how to deal with the patients which needs clinic supports. And simple one-day seminars, webinars or things like that may not be the complete thought. It has to be connecting this trainee into reaching the kind of patient. The second point which was brought in is understanding the need of patient. One of the major challenge, especially when the patient is sitting in front of you, we are all, I think we are having our vision with us, God is kind, and we may not understand what this person who is suffering the visual impairment is going through. What is the need of this patient? I would say that the whole theory and science of prescribing these devices depends upon understanding the need of the patient. There is enough of chair time which the practitioner has to give to a single patient, at least maybe an hour of conversation, to practically understand what the lifestyle of this patient is and what does it mean. But as an optometrist, we are taught well and we understand magnifiers, magnification and in-clinic kind of thing. When we examine a patient, it's not visual acuity charts are not real life situations. This is not what is expected. But the patient who has come to us on this is examined only on the low vision charts. And most of the time we understand this practitioner is not entering into the life or the domain of the patient, and hence the outcome of the device which is prescribed is most of the time a waste for this patient. So point, it needs a good chair time, really understanding the patient, and one has to enter into the life of this blind life to understand what it is going through. Next point, of course, is money. Already mentioned by Dr. Ashi that money, which was point brought in, it's not a viable option. When I moved into low vision practice also, I do other practices also in specialities. But when I do a low vision workup, I do not get the money back for the time that I have devoted for my patient. It may not convert into sale. It is not the real value. It's more of a philanthropic work which I would do for my patient. But it is not the concept of every practitioner which they are going. There are certainly young ones are here to take that as a career where they can make money. But truthfully, the practices or independent practices are not a viable option for anybody to sustain a low vision practice, to invest lakhs of rupees for the equipment and then rehab connect. So what is more important is these have to be hospital based setups, and rehab centers, as was pointed out, could be a part of this unit itself, and then only a good low vision can be done. Yes, an independent low vision practitioner can just give a basic kind of equipment or devices, and not everybody can invest. So now I'm going to talk about last recommendation, which is certainly an add to the point of what Binny has been saying. So Binny, we met in the conference and I'm very privileged to have met her. She's a rehabilitation counselor. We started getting into conversation as friends after this conference. So she understands the patient. So all the whole gap is optometrist is taught the technical part. They definitely know very well about the magnification calculations, various devices, what to prescribe. I don't think when somebody who's educated on it in a curriculum of a 4-year degree program is learning less. But what he is not learning is the rehabilitation part. And rehabilitation counselor, where Binny was sitting, she really understands the patient. In fact, she doesn't understand anything on the technical part. She wouldn't even know what an eye anatomy would mean, what the device would mean, what it all means, and she is here rehabilitating the patient. So the bridge has to be between the two. One such model which we experimented was Binny came forward to say, I want to learn technical part. And online, and it's the beauty of her abilities that we could, every Sunday we could sit down together and online give a model where we started with anatomy of eye. Now she goes into the hospital back again to see when I'm giving her. She's gone through all the lectures which we teach our low vision optometrist. It's so easy for her to understand now, and she comes back and says, there was a patient with this. Why wasn't this device prescribed to this patient? So see the linkage which she has, because she has the time, she is understanding the needs, she knows some part of the device, and she can go back to the optometrist to advise on it. So I think one of the advocacy or recommendation which I would suggest is optometrist, good, technical knowledge, but there has to be a rehabilitation counselor who has to be also brought into this technical stream to understand. So non-eye care practitioner workforce is something which we should tap, and they can, they do it with empathy. How much these people would understand and what serious connection they would bridge with their patient, none of the optometrist or an eye of a hospital or a ophthalmologist, I think, can do that part of it. So this was majorly what I wanted to discuss, and wanted to say that this model is what the future is. Awareness building, more knowledge. Yes, very sad data to see that 84% are not aware, and I can count on fingers. There are very few optometrists who do it or move forward with it, but we have a model to evolve. Teaching an optometrist is not difficult. He's gone through a curriculum. You need to upskill them, but bring in the non-ophthalmology workforce into it. Somebody who understands the visual impairment, and I think it will work better. Thank you so much.
Thank you, Professor Monica. Thank you so much. Very beautifully presented. I also brought very important aspects of the management of the rehabilitation, starting with the understanding the needs of the patient. And also you mentioned that given the limitations of the kind of the low vision work, it has to be a hospital-based setup. And also an important point you mentioned about the tapping the non-technical people and their abilities. I think a very, very important point that you really touched upon. Thanks so much, Professor Monica. So we'll move on to the next one, Mr. Mahendra Singh, please. Mahendra.
Yes. Good evening, everybody. So, CL Gupta Institute providing its service since 2009, and we have started our internship since 2013 to continue, and optometric fellowship since 2013. And about me, I have done my subspecialty in low vision from LV Prasad Institute, Hyderabad in 2015. And in our low vision clinic, daily we have around 4 patients in our average OPD. And if we talk about the benefited patients, so suppose we are sending the 100% in the low vision clinic, so it means they will get the 30% benefit from the LV department. And if we send the rehabilitation patient in the low vision clinic, so it means the visual impaired patient, they will get the 100% benefit from the rehabilitation department. And if the person is totally blind and have in childhood, the patient will get the 100% satisfaction from the vision rehabilitation department. So these are the some activity that we do in Northern India in every year. So along with me, since 2015, I am doing this same sort of workshop in CL Gupta Eye Institute, that is national level conference that we do, and we focus on all the norms that we should do related to the low vision. So we make the awareness, and we give some sort of low vision training, how even they can basically prescribe the low vision devices in their practice, or even that is good for those who are planning to start the low vision clinic also. We gave them some brochures, information, or contact information, and the contact information. From there, they can get the basic low vision devices. So we started our low vision workshop since 2017 and 18, 19, and every year we have the conference related to make the awareness in the newcomers for the optometry background in the eye healthcare practice, and even in the ophthalmologist or those who are practicing in the eye care. So these are some photographs that I'm sharing with you. So every year we have the same workshop to make the awareness in the eye healthcare practice. So these are some basic pictures. Some of the pictures I have put it here. This is our low vision department. So since I was working in the low vision department, and then I feel there is some lack that I cannot fulfill it in my hand only, that I can prescribe the low vision devices and some recent support service to the patient, but we needed somebody who, like the visual impaired, or even those who are already trained in this field, so that the patient will get some idea. Or even in the first time, maybe the patient is very frustrated. They said, okay, no, I don't want this service, but after seeing the Binny, definitely they have some concept in their mind. So they should start something back. So again, they came back and they called to the Binny madam, okay, Binny madam, just can you tell us what we can do the next. Okay, so these are some photographs. That's what we do. We are basically focusing on the educational. We gave some electronic device training to the patient, those who are like want to read something on the laptop, mobile, or want to operate some digital things. We gave them this sort of training to the patient. We gave some vocational training to the visual impaired patient in our clinic. We teach them how to prepare some origami, candles, and then some paper. And we gave them some training related to the like orientation, mobility, and some sort of that dancing also in our rehabilitation department. So basically, this is as already proven, and our practice, we feel the LV service waiting for the attention. And that attention is basically from the towards like the everybody from the ophthalmologist side. Okay, so if they say to the patient, in our institute, maximum we have refer for the internal side, or that is in our system also. So somebody doctor said, okay, you can go in the rehabilitation department, the patient follow. So my recommendation will be, if we can send the patients by the point of ophthalmologist side, we can go for the rehabilitation part. So it means that part should be the like treatment part for the patients, the counseling and some devices, orientation and mobility, and teach them some training to the patient. So that should be the part of the medical management. And the mostly what we feel is the ignorance by the family. The family member also said, if the somebody is visually impaired in their family, they said, okay, I will take care, we will take care in the entire life. And we generally came across with the patient in the pediatric age group and the adult age group. In the pediatric, they say, okay, we will take care. And when we came across in the adulthood patient, they said, okay, who will take care? So these are the problems that we are facing. So we have to make the awareness as well as in our community also, as well as the related to the patient community also in their caregivers also. So the recommendation is the person should be timely communication to the patients about their prognosis and their problem, because some of the patient, as we know, retinitis pigmentosa and the advanced field loss, maybe they can come up with like 100% visually handicapped after the sometimes. So we have to counseling them, sir, your vision or like your acuity will be hampered after the sometimes, but you have to take Thus, some help from the rehabilitation department. They will teach you and they will guide you. So these are the some recommendation. And vision rehabilitation service. And every year, as I said, we are organizing this type of program and the conference. We do continuous CME. We send them some mails to our like in alumni group also. If you are finding this type of the patient and comes in this criteria, so generally you can refer this patient to our clinic. So definitely we will try to help them in the better way related to the vision, related to the like low vision devices, it in any form. So because we have optical devices and non-optical devices, nowadays we have started the some advanced software also with us, like how to operate the mobile, how to operate the NBA software as we generally do. And this is our last, the policymaker also should decide about and every institute and the every institutions, the persons and any ophthalmologist also, they should have some referral policy. If somebody having total visual impaired, so they should say, okay, so you can go in this place, definitely you will get some idea, or maybe you will utilize your functional vision. So our services, we generally give the low vision aids to the patient, and educational things, yes, we do. And vocational training we are giving to the patient. And we have in our end, we generally take the patients and we are sending to the patient for the government hospital to get the visually handicapped certificate. So these are the things that we do in our end. And if we do the study and we find out the maximum patient is waiting for the like ophthalmological recommendations. So at least they should refer to the patient in the low vision and rehabilitation department. Thank you.
Thank you, Mahendra. Thank you so much. I think you made one important observation that people with still having the residual vision still tend to go to blind schools and learning the Braille. I think that's an important observation. So we will deliberate upon it. So can I request now Nikita Sethi, please have your perspective. Mahendra,
Hi,
you can
Dr.
stop your share
Phanindra
screening.
and the other panelists. First of all, I would like to thank you for this opportunity, because I'm a newbie, and giving me this opportunity and letting me put forward my point of views is really great for me. So as a fresh graduate, I will address me as a fresh graduate only. So after coming into the teaching role, I have noticed certain points which have been beautifully stated by the other panelists, that we look forward and we find out, we provide them vocational trainings, we fill up the gaps. But like I saw in the comment box also, that someone commented as a question that we do not have the devices. So I think this is one major point to address, is why just to wait for the devices and not start from the basic level. When from the first year of the curriculum, we tell the students our visual acuity should be 6/6. We need to focus on 6/6. The moment 6/6 is not there, the next step is pinhole. And if their vision does not improve, the next thing is they shut down their minds, and immediately the next reference is send them to the ophthalmologists. But the optometrist usually, sorry, this is the sad part, but as an optometrist, there are very few who follow up it with the ophthalmologist as to find out what is the reason for no complete vision or no improvement in the vision. Being blessed with the knowledge and being exposed to the knowledge about what are the reasons for not getting the full corrected vision, we should be knowing that, yes, what will be the prognosis of that disease. Like, for example, I'll just talk about one or two diseases like cataract. We know very well that cataract can be operated and the vision can be back. Of course, in some cases, in severe cases, it is exceptional. But in majority of the cases, the vision can be back. So there's an option with us. But there are certain cases like RP is there. We know about the diseases that the vision won't be back. So why to wait for the diseases? We can empathize with the patient. We can talk to the patient. We can devote our time. We should never be in a rush to finish the OPD. If we find out such patients, it is not just curriculum based. We have been given the title as low vision. So only if we'll have a setup of low vision, then only we'll be able to work up with the patients. There are many things which you can do as an optometrist at the basic level also. Like, for example, this is a beautiful example which I always quote: near vision problems, right? Our phone is the best low vision device. You have so many options. Carrying smartphones every day in your pocket, that's the best low vision device that anyone could have. You can change the brightness, you can change the font sizes, you can change the contrast as well. So why aren't we using those things as the base of your low vision treatments? Why we are just waiting like as to uh, we should have a handheld magnifier or a telescope, then only we'll be working with the low vision patient? So that is something I want to recommend, that as an optometrist, just don't wait that you'll be given that device, you'll be said, okay, this is a low vision setup and this is a handheld magnifier, this is a telescope, and then now you need to work it up with the patient. Take best possible utilization with whatever you have. You have an overhead lamp, just increase the brightness, ask the patient to increase the brightness, and it works wonders. So small things, just don't wait for things to come to you and then you'll organize it. You have a lot of knowledge, everybody knows physics and basic maths, so I'll just limit that to this only, that start it. And the next possible point is reference. As an optometrist, ophthalmologist, as stated by Dr. Sumit, they're very busy in surgeries and finishing up the OPDs. As an optometrist, you should know when to probe for low vision consultation. Yes, this patient requires your attention. So you tell the ophthalmologist, you guide them, you take the lead and follow up with the patient. You take extra time, you devote that time, take out some time from your OPD and work it on. Right? Just don't be in a hurry to send off the patient, sorry, you have this disease and the vision will not improve. Sorry, but this is very disheartening for the patient. And immediately, if I change the statement and say, oh, yes, okay, you have this disease, but we have certain things which will help you out. Right? So these things will, create a positive impact on the patients with low vision as well as blindness. So try to do whatever maximum possible options you have and just don't wait for things to fall in place. I think I'll limit that to this only because other points were beautifully covered by my fellow panelists.
Thank you, Nikita. Thank you so much. Very beautifully, you have actually made your points. So we're just getting time out. So, but we'll take up two questions which are there. I think partly Nikita has already answered one of the questions. So I think one question is about the small, especially small places. How do one get the low vision aids? So that's question from Anandpur Sadhguru Seva. Anybody can take up this? Any of one of you, please?
It's not a problem. It's actually people not being aware of where to buy it from. So there are some suppliers in the country. So that's where the training doesn't mean, and that's one of the, again, an example which we are trying to set in. And I said with that example where we just did not teach the product, but where to buy that product from. We had the distributors right from every place brought in, who showed there was no commercial interest, but there was a complete linkage which was built by this device, this distributor, this supplier, and individuals went in. So 16 out of 40 people could straight away start practice, and one of the remotest place was Dungarpur, which is 50 kilometers, and this did not even have a proper eye hospital where they started a low vision setup, So another possible reason, yes, everybody cannot invest in all the devices, but there are primary, secondary and tertiary level recommendations. But if one has to do low vision workup in totality, I don't think everybody would be able to invest that kind of manpower and instrumentation. So the services, yes, So the awareness building is not only on the knowledge, but it has to be where to get these products from. And I fully agree. This should be part of any training whenever we do that.
Thank you, Professor Monica. I think probably the another one is seems to be a comment. Yes, from the day one, one has to really take it seriously and explain to the patient. But also, I think how to manage low vision patient so that, so it will improve student skill. I don't know. I didn't get this question clearly, but perhaps it's about. I mean, so we're here. We're not really discussing about the clinical aspects of managing the patient, but I think it's it requires just separate discussion. But overall, we discuss about the issues and recommendations that have come up from the annual last conference held in month of March at CL Gupta. So I'm just taking a couple of points from what the panelists have made presentation or talked about, and very important aspects. Particularly, Professor Monica brought an important aspects about tapping the non-technical people, like in the case of like Binny's example, she is quoted, and tapping on their abilities to link them and bridge the gap with the clinical people, who are technically competent people like optometrists. So that is one. I think we need such kind of experiments and more of kind of that kind of the learnings and documentation of those learnings from those models is very, very important. I think that's one comment that I'd like to really pass it on. And also that Sumit point about the schemes of the government for the on the low vision rehabilitation aspects. Yes, I think probably many of these service providers are not even aware of those government schemes. So there is an issue about the lack of awareness on not only technical or some other aspects, but even the schemes from the government also. I think one has to really know and take benefit of it wherever it is the scheme is available at least. Instead of leaving completely, I don't know. But yes, there are schemes from the Ministry of Social Justice and Empowerment. I think one has to really take the advantage of it.
So
And
I think Dr. Fanendra, Dr. Sumit's
yes.
book was the only one where I could find everything under in one concise place, where otherwise there is no portal where you will get all the information about rehabilitation, about government facilities for visually handicapped.
Okay, very good, very good. I think that's really a need of the hour for the people, kind of questions that we are getting for the people. Like, we don't know where to go. I think that books really answers the question. And very importantly, I think all the panelists have brought one common point that I've noticed is the low vision rehabilitation service not a career priority. And it needs to be commercialized. Those kind of aspects we got it. And given the lack of the ecosystem and the return of investment, these are the kind of points that we brought in. So I mean, I think seems to be that the panelists are agreeing to coming to a kind of consensus that yes, it is not a return of investment, but it's more of, as Professor Monica said, it's more of a very philanthropic kind of angle to that. One has to probably see that. Is that kind of consensus that we are having? Any kind of thoughts on this? Any comments on this?
I don't know. It should be one of the
maybe
major concerns.
Nikita, Dr. Rashi, Dr. Sumit, anybody, please.
I would, am I audible?
Yes, please. Yes, Binny, please. You're audible, yes.
Okay. So basically, as Monica Mama said, it's quite right. And what I would suggest is that, that youngsters should be, encouraged whichever way to go for to choose low vision rehabilitation as a career. So if money aspect comes in, but maybe we can start step by step or slowly. I think we should, make a step ahead. So what I think. Thank you.
I think in the curriculum, when we are involved while teaching itself, the feedback of the patients, the beautiful smile which they give after the improved vision, I think many are, motivated after that also. So that also acts as a motivating aspect for, moving ahead in low vision career. of course, that's true that the monetary part is important, but again, I think motivation with that, revert back from the patients is very important.
My personal experience for all these decades that I have taught optometrist, every batch that we come out, we can count on fingers. And those who have gone and practiced would be people like Mahindra, who's working in a beautiful setup where he has the resources to do all the low vision and the rehab point of it. But as an individual, they would not like to get into it. There is a gap in it. They are quite motivated, but as I said, it's a time consuming process. It is not easy for everybody to take it as a successful career. They are doing it only if somebody has a philanthropic mind towards this. But when, the other thing is, we teach in the curriculum, it is quite exhaustive if it is a 4-year graduate program in low vision. The only issue comes is, he's as an intern in a hospital, that particular hospital also is 0 level at low vision workups. So he's not rehearsed his low vision practicals. So he's not got confidence back into it. 70 to 80% of the hospitals or the clinics where these students go, and nowadays the students are getting more internships in places like optical chains like Lenskart and Titans and others, who are totally clueless about low vision. So whatever has been done at the university level is undone in the internship. So at the end, he realizes my career is spectacles, contact lens and other things. He does not understand low vision as a career. So integration of clinical training as an intern, and probably if every hospital would have a low vision unit, I think that will only enhance the services to go into a vaster area.
Totally agree with you. Mohit.
Yeah, I would like to add just the final comment from my side over the adding on to the discussion, that the motivation comes from the knowledge and training and empowerment of the non-ophthalmologist human resource, robust training and the industry support. Why the spectacles thing and the contact lenses, orthokeratology, they are all flourishing because of the extensive marketing by the industry and industry support, indirectly coming up from the demand in the market. And we have to, again and again, I'm telling, the creating awareness among the professionals as well as the end users will bring on the change, will bring on the, felt need, demand generation, industry support, and I think the flourishing practice of low vision. Otherwise, you have to maintain an integrate balance between the altruistic goals and the self-serving goals, and have a philanthropic mindset for low vision.
Great. Low vision or not no vision. That's a title of the book, which is available for a free download from the mehfindia.org. Thank you, Dr. Sumit. So thank you all. I think so. We have no further questions. So great show. I think so. All of you, thank you so much.